afternoon, everyone. So, my study was on effect of motor imagery training on gait and balance in Parkinson's disease. It was a 12-week prospective interventional study, and it was done in a tertiary care hospital in New Delhi, in the Department of Physical Medicine and Rehabilitation with Department of Neurology um, as a helping department. So, as we know about Parkinson's, that it is one of the movement disorders. Um, it is a neurodegenerative condition. The main so in my study, mostly focused on the motor deficits, the motor deficits and the gait uh, disturbances in the disease. So the patients had a postural instability, which was characterized by anterior trunk flexion, and there was rigidity in the joints, and there was execution failure like bradykinesia, stiffness, and resting tremors. Uh, Also, the gait disturbance that we saw in Parkinson's was the fascinating gait, which had very small step length and decreased walking speed, and there was tremors while changing the directions. So, and also there was increased risk of fall while they were changing the directions. Um, so Parkinson's is a primary driver of disability, and it is the second most prevalent neurodegenerative condition. It follows only Alzheimer's. Um, it's a progressive disorder which result in continuous deterioration of motor capabilities over time. In Parkinson's, we see problem with uh, uh, execution of the uh, tasks, the initiation of the task. So the once the patient is performing a task, he is able to complete it, but it's very slow, which is termed as bradykinesia. So in our study, we took sample we divided our study into two groups. Group A was had conventional exercise therapy that focused on range of motion exercises. It was given strengthening exercises to build their endurance and physical balance training. And there was the another group B, which was given conventional exercise therapy along with motor imagery training. Motor imagery training, it is basically the patient. It is training of the functions of the tasks that are otherwise unconscious, which are the patient has to rehearse the movement in his brain consciously. So it is conscious visualization of the motor tasks. And the goal is to strengthen the mind muscle connection, the brain muscle connection, to bypass the unconscious execution deficits. So, um, we had to the hypothesis was to evaluate the effectiveness of adding motor imagery training to conventional exercise therapy in altering the trajectory of gait and balance and overall progression in Parkinson's disease. S- It was a 12-week study, and we had done it in the month of January in 2021 to 2022. Um, but the main reason for us for doing such a study was that in Indian scenario, such a study, we did not have any study which was including motor imagery training in Parkinson's. So we had the inclusion criteria involved confirmed Parkinson's diagnosis, intact cognition, and we had to make sure that the person was capable of imagining the kinest- kinesthetics. And group A, the terracotta is for group A, which who had 45 minutes of conventional exercise therapy for 3 days a week, and it continued till 12 weeks. And group B had 45 minutes of CET. CET is conventional exercise therapy with 20 minutes of MIT, and it was done for 3 days a week. The compliance had was ensured by tele-rehabilitation and video clips due to COVID-19 pandemic protocols, and since the patients could not attend the hospital on a regular basis. So we had we had taken a total sample of 50, because it was reduced from the target of 80 due to COVID restrictions, and the mean age of both the groups was around 60 to 65. Group A was 63 and group B was 62, and males dominated the study, because females generally didn't show up for their illness. And the groups are statistically comparable across gender, age, gender, and Hohenjahr stage. So, HY stage, I would like to tell here that HY stage is the staging that we do for Parkinson's disease. It is done in the stage 1, 2, 2.5, 3, and 4. We took patients till the moderate stage. We did not take patients of the severe stages because they were already disabled. So they did not, their motor symptoms were already not present. That and they were restricted to wheelchair. So that is why we took only till moderate stage. The outcome the outcomes that we measured was the balance assessment. The tool we used was Berg balance scale, and timed up and go for the functional mobility, and endurance and gait for measuring endurance and gait we used 6-minute walk test, and overall disease progression was done by unified Parkinson's disease rating scale, parts 2, 3, and 6. The part 2 showed was used for motor symptoms. Part 3 was for uh, activities of daily living, and part 6 is for independence, percentage of independence. It is expressed in independence. And this was the result that we got in Berg balance scale. At so we followed up the patients at 4 weeks, 18 weeks, sorry, 8 weeks, and 12 weeks. So uh, the Berg balance scale showed the static balance, and it increased in both the groups. But the intergroup, the p-value came out to be 0.414, which was not significant. So it showed that both groups showed that there was in clinical improvement. And in group B also, we saw that the intra-group uh, uh, result uh, was better, but uh, overlapping trajectories prevent intergroup statistical significance, meaning it was the result was that there was clinical improvement, but it was not statistically significant to conclude that it was that motor imagery training did better. And in case of 6-minute walk test, the intergroup, so we can see in this graph that the 6-minute walk test, the distance increased in both the groups, in group A as well as in group B. Group B is the blue one and group A is the terracotta color. So it increased in both of them, which showed that conventional exercise therapy is also playing its role, and MIT is also increasing improving the result. But it was, but the intergroup p-value came out to be non-significant. And in UPDRS part 3, motor symptoms, it showed that intragroup improvement was there, which showed that p-value was less than 0.05 and there was no significant intergroup difference. The clinical reality was the addition of motor imagery training generated superior absolute medians in functional mobility, like timed up and go, which decreased from 7 seconds to 4 seconds. In timed up and go, I would like to mention here, we had to start. We made the patient start from a chair, stand up from the chair, and then move, complete the distance of 30 meters and take and turn around and come back to the chair. So that showed that was used for uh, the the mobility of the patient, and it dropped from 7 seconds to 4 seconds. And in work balance scale, which also reached from 50 till 48. Um, then the statistical reality showed it was the contrast against the highly robust independent success of conventional exercise therapy alone was not wide enough to break the p-value, the significance threshold. So it was effective, but CET is a formidable baseline. But we cannot over we cannot overlook the importance of CET. um, in my review of literature, I found that the papers from Braun et al. They did not find any significant difference between MIT and relaxation and CET using the 10-minute walk and timed up and go. Silva et al. In a study in 2019 found neither group superior in timed up and go and 10-minute walk test. The studies that favored motor imagery training were in 2007, Tamir did a study which observed significant intergroup improvement for motor imagery training in uh, timed up and go. And in Elvishi in 2013 and Kashev et al. Did independent studies which found that motor imagery training statistically was superior for balance and motor function. So there were some disparities in in my studies also, like the sample power. We took the sample power. The study utilized sample of 50, and the previous studies showing MIT superiority frequently relied on smaller cohorts, which increased the margin of variance. The decrease disease severity. Our cohort featured HY stages from 2 to 4, which was moderate to severe. Superiority studies focused on stages from 1 to 3 because motor imagery training required cognitive initiation. Advanced severity may blunt its specific theoretical advantage. And the literature lacked standardized outcome measures, complicating direct 1:1 cross study comparisons. There were limitations with my study as well. Like my study, the target sample size was reduced due to the strict COVID-19 hospital mobilization protocols, and specific patient comorbidities were not factored into the final multivariate outcome analysis. And 12-week follow-up provides excellent short-term efficacy data, but long-term retention of kinesthetic motor skills remained unmeasured. So there were some clinical conclusions in the rehabilitation, like motor imagery training is a highly beneficial, non-invasive, and adaptable tool for Parkinson's rehabilitation. While its addition to a rehabilitation program improves the outcome, it currently matches rather than statistically exceeds the robust clinical benefits of active conventional physical exercise alone in moderate to severe patient cohorts. We can conclude that to definitively isolate the quantitative advantage of cognitive motor rehearsal, the PMR community requires multi-center, long-term randomized control trials featuring larger cohorts and strictly blinded assessors. Thank you, everyone.
Good afternoon, everyone. I'm Dr. Parinita Jindal, Institute of Intellectual Disabilities, Grid, Chandigarh, India. My topic of my presentation is role of self-affirmations and yogic relaxation techniques on building stress resilience. This is the abstract which I submitted with my biography. Please, Nick. Stress has stress has become a common challenge that, when persistent, can negatively affect emotional balance and long-term health. Stress also leads to difficulty in carrying out daily tasks. Stress is a common word used in everyday life, and it is derived from the Latin word stringer, which means to draw tight. It was used in the 17th century to describe what place a person at risk for disease. An optimum amount of stress is required to propel an individual towards applying the efforts to complete the work. A situation may be less stressful for one individual, whereas for another individual it may cause a huge stress. Therefore, the stress might become as perceived. Perceived stress is a state of emotional tension experienced by an individual. It is when one is trained the ability to and creates physical and psychological problems in oneself. There are different coping strategies that are there to build resilience to stress and work effectively. Resilience is the ability to adapt to adversity and bounce back from that stress. It is also referred to the process of effectively coping with adversity, trauma, or significant threats. Now, what is building stress resilience? When my topic is talking about building stress resilience, so it is important to know what is building stress resilience. The ongoing practice of increasing self-awareness, reframing challenges, and developing coping mechanisms so you can bounce back to your baseline faster. That is building stress resilience. It involves actionable daily habits and mental shifts to handle setbacks with more ease. The aim of my study is to explore the role of self-affirmations and yogic relaxation techniques in building stress resilience through self-introspection and literature review. Next slide, please, ma'am. In this study, self-affirmations and yogic relaxation techniques are two coping strategies that I should like to explore. The objectives, next slide, ma'am. The objectives in this study are to explore the role of self-affirmations in building stress resilience through self-introspection and literature review. Second, to explore the role of yogic relaxation techniques in building stress resilience through self-introspection and literature review. That is, there are two coping techniques, self-affirmation and yogic relaxation technique, and there are two methods through which I would like to explore these techniques, that is, through self-introspection and literature review. Now, it is important to know what is a self-affirmation. Self-affirmation is the act of validating one's own worth, values, and identity. It focuses on personal strengths, core values, and past achievements to reinforce one's esteem, build confidence, and maintain a positive self-image when facing challenges. According to Merriam-Webster Dictionary, it is an act of affirming one's own worthiness and value as an individual for beneficial effect, such as increasing one's confidence or raising self-esteem. Now, self-affirmation is a term which was given by Claude Steele. According to him, we all have a basic human need to maintain a positive sense of self-integrity. When this integrity is threatened by failure, criticism, stereotype, threat, we feel stress and defensiveness. Affirming important values, not just performance, restores our integrity. This frees mental resources, reduces defensiveness, and improves openness, motivation, performance. In this image, you can see clearly that there's this girl, and she's feeling threatened. There's some threat to her self-integrity. A situation challenges my competence, values, or worth. There's criticism, there is pressure, there is failure, negative feedback, and she feels doubtful and threatened. In the second picture, there's she feels that threat has put her integrity at risk. So when threatened, she has to defend herself. Then in the third picture, it is like I affirm what matters to me. Now, what does self-affirmation do? In this self-affirmation, she will reflect on her core values, strengths, roles, or things that are important to her. She will reconnect with what truly matters to her. So now, in the fourth picture, self-affirmation will restore integrity to her. She will feel secure from within. She will feel capable, valuable, and in control again. And when we use self-affirmation, we use the word I. So here we can see below, we can see the line, I feel capable, valuable, and in control again. In the fifth, threat loses its power. Once the integrity is restored, the threat loses its impact. Now she's confident that I can face challenges calmly and clearly. And in the sixth picture, integrity is safe. And now she says that I grow stronger. I stay true to myself and grow in confidence, resilience, and well-being. So there is greater resilience, better performance, emotional well-being, and stronger sense of self. So we have to understand that self-affirmation is not self-praise. It is reconnecting with what is important to us so that we can face challenges with strength and integrity. Now let us move to our second coping skill, that is yogic relaxation techniques. A relaxation technique is a process, method, procedure, or an activity that helps a person to relax, to attain a state of increased calmness, or otherwise reduce levels of anxiety, stress, or anger. In this presentation, I'm talking about 2 or 3 types of relaxation techniques. Though there are many relaxation techniques available these days which can be used as per one's individuality. The ones which I have used, which I'm going to talk about here, is mind sound resonance technique, that is MSRT. Second, deep relaxation technique, that is DRT. And third, Shavasana. Now, mind sound resonance technique is one of the advanced relaxation techniques of yoga, which have been developed by Swami Vivekananda Yoga Anusandhana Samsthana, Bangalore, India. It is one of the mindfulness-based yogic relaxation techniques. Second relaxation technique is deep relaxation technique, as practiced by Swami Vivekananda Yoga Anusandhana Samsthana, Bangalore, India. It focuses on part-by-part relaxation of the whole body. Third relaxation technique, which I would like to talk about, is Shavasana. Shavasana can be done with music, without music, with instruction, or without instruction. So it all depends on one's individuality, what one likes to adopt as a coping skill. Here I'm taking these 3 techniques, MSRT, DRT, and Shavasana. Now, in this, we can also see in this image that when self-affirmations and yogic relaxations are combined, right? So it converts into emotional regulation and stress resilience. However, in the next slide, more vivid picture can be seen of it. In this picture, there is a very vivid thing has been shown when self-affirmation and relaxation techniques are combined. See, there is a threat, there's stress, there's self-affirmation that I'm capable, I'm enough, I can handle this. Then there is relaxation technique. There are relaxation techniques, MSRT and DRT. Then there are outcomes, calm mind, emotional balance, reduced anxiety, and stress resilience and right decisions. We are able to think calmly, choose correctly for ourselves, and choose rightly. Right? We are able to lead to wise and constructive decisions. So there is emotional balance, mental clarity, and strong stress resilience. In one method in this presentation was self introspection. Now I've not been very regular in it, but whatever I could observe from time to time, I have tried to just make observations from that, right? not exactly noting it down, but made observations through that by recalling it, whatever I could. So on the basis of that, I could I chose just four aspects on which I made my observations. First is like physical relaxation, second, emotional regulation, third is internal dialogue, fourth is cognitive reframing. In self affirmations, when I talk about personal and professional aspects of life, it was mainly that my mind and respiration got better. In relaxation techniques in my personal and professional aspects of life, again, my body systems became relaxed. Then in emotional regulation, it reboosted confidence. In by relaxation techniques, better understanding of stress reactions was there. Though sometimes it happens is that one techniques works better for one situation and other techniques works better in another situation, so it could interchange depending on the situation, depending upon the problem. But it is just on the whole that I felt what I felt. I'm sharing it with you in this paper. So there was internal dialogue, which was constructive thinking, and internal framework to have doing relaxation techniques. There was an internal framework which was laid down in the mind, because all it is like all the problems that start with usually are said like they're psychosomatic, but even outside environment you cannot control, so you have to just work on yourself. So it's that in the through relaxation techniques, internal framework was laid down to have a self talk. Then there is cognitive reframing, positivity towards problems in life, for example through self affirmations like accepting the change and letting it go, and through relaxation techniques dealing with problems at physiological level, keeping relaxed, accepting the change. Some of the things I'm sharing with you here. Then there is literature review. Some of the literature review which I would like to share here in this presentation is um, these are some of the latest. Like first one is the impact of self-affirmation interventions on well-being, a meta-analysis by Zhang, Chen, Hu, and Wang. They conducted a meta-analysis in which they identified and coded 129 independent tests derived from 167 published articles, and overall results suggested that self-affirmations can significantly improve various aspects of well-being with both immediate and lasting effects. So self-affirmations do have an impact. Second study in which there is effect, the author explored effect of Jacobson muscles relaxation technique and positive affirmation on stress level among second year BSc nursing student quasi experimental study. They evaluated the impact and both found that both interventions significantly covered stress levels, and positive affirmations were particularly effective for moderate stress, while Jacobson's technique showed efficacy for severe stress. Demographic factors did not significantly influence stress levels. When I talk about combined effect relaxation and self-affirmation in one of the previous slides, so this study can become a guideline towards the further study in this direction, which I think. So I'm sharing accordingly. Then third study, which I'm sharing here, is the impact of self-affirmation on individual stress levels and performance, a longitudinal study. The study had hypothesized that the participants who undergo the self-affirmation intervention will score higher on the mathematical test and will report lower levels of stress. So in this study, the author reviewed that self-affirmations have been shown to help individuals to see the stresses of their daily lives from a broader perspective and focus on the big picture, therefore causing the threatening situation to require less cautiousness and vigilance. In the fourth study, that is self-affirmation activates brain systems associated with self-related processing and reward and is reinforced by future orientation. This study highlights how reflecting on core values activates brain networks linked to self-reflection and reward. To know about neural activation, uh, in this paper, they have highlighted that how functional MRI studies reveal that self-affirmation spikes activity in the medial prefrontal cortex and posterior cingulate cortex, which are the brain areas responsible for self-related processing. And regarding the reward system, it also triggers the the ventral striatum and ventromedial prefrontal cortex networks heavily associated with positive valuation and reward processing. So self-affirmations are definitely useful as per review of literature, which I have explored till now. Regarding literature review of yoga relaxation techniques, first study is effective mind sound resonance technique and deep relaxation techniques on mental efficiency, perceived stress, and activities of daily living among geriatrics. The study was conducted by me with my PhD guide, Professor Dr. Anuradha Sharma. And in this study, MSRT and DRT was administered to the geriatric participants for 15 days, and the stress levels were assessed before and after. And it was found that DRT, that is deep relaxation technique, was significantly more effective for reducing perceived stress as compared to mind sound resonance technique and control group. As compared to so DRT, deep relaxation technique, was significantly more effective. In the second study, that is cross-cultural study on the effects of on the 10 days of online mind sound resonance technique on state, anxiety, stress, quality of sleep, and mindfulness by Super et al. In this study, there was a statistically significant improvement in restfulness and an improvement in insomnia. In the third study, which I have covered here, which I'm talking about, it is effect of mind sound resonance technique on stress and emotional regulation on elderly women in old age home by Dio and Rani. In this, the elderly women received the practice of mind sound resonance technique for 30 minutes per day for a month and were assessed for their stress levels, wherein it was showed that there was a significant reduction in stress levels. In the fourth study, it is by Rao, Maitri, Raghuram, and Hongasandra. It titled Effects of Mind Sound Resonance Technique on Psychological State, Sleep Quality, and Cognitive Functions in Female Teachers, a randomized controlled trial. So it was a study conducted on teachers and 60 female teachers, and MSRT was given for 1 month, and there was reduction in perceived stress. So this is regarding yoga relaxation techniques literature review, which I wanted to share with you and possible to share here. Now, what I could derive out of this presentation while I was working on this presentation, it can be said from self-introspection literature review, it can be said that self-affirmations and relaxation techniques like MSRT, DRT, and Shavasana with instructions or without music are beneficial in building resilience to stress. And of course, there are a number of coping skills. The process is gradual. There are individual differences and there are individual problems that do exist. But as per my subjective experiences from time to time and the literature review which I went through, it was possible for me. It brings the change that is as follows. That is physiological changes such as neural changes, rewiring the brain, and psychological changes such as cognitive reframing and emotional regulation. So in the end, I would like to thank Almighty for giving me strength to present this PowerPoint presentation. And I extend my thanks to who helped and inspired me directly or indirectly in making this PowerPoint presentation, such as AI sources like ChatGPT and journals, whose research papers were easily accessible to me. I also thank my family for valuable feedback. And thank you to the organizers for giving me this opportunity to present on this esteemed platform before all of the lovely audience. That is all of you. And all the best to all of you also, and great presentations till now. Just an appreciation, a humble appreciation from me. So once again, thank you to all. And these next slides are the references. Yeah, I've given some references here, which were useful in making this presentation. Thank you so much, everyone. Thank you so much for this time, for your valuable time, for sharing this valuable time with me. Thank you.
subject is a corrective emotional experience in imago couple therapy, online and offline applications in light of neuropsychological research. Imago relational therapy is a method of couple therapy invented and developed by Harville Hendricks and his wife Helen LaKelly Hunt. At its core lies a profound truth. We are relational beings from birth, inevitably scarred by the imperfect nurturing of our caregivers. Yet paradoxically, it is within the crucible of a loving relationship that we find our path to healing. IRT uses egalitarian dialogue. Imago relations therapy uses egalitarian dialogue to facilitate re-experiencing of painful memories originally experienced in childhood formative years and the defenses created in the past. The structured interview, dialogue, not interview but dialogue, encourages attentive listening, mirroring, and empathic and validating responses, gradually helping couples process these experiences and shift from futile power struggles or deadlocks towards a healthier, more satisfying relationship. Next slide, please. Next. Okay. What can we learn from up-to-date neuroscience findings to understand and further intensify the therapeutic effect of imago couple therapy? Let's go back to the concept of corrective emotional experience. This is a concept originally coined by psychoanalysts Franz Alexander and Thomas French about 80 years ago. The intention was that the patients re-experience the unresolved conflict from the past, but with a different outcome, with active participation of the therapist who provides compassion and encouragement. It marked a sharp departure from the psychoanalytic approach prevalent at the time, which emphasized the therapist's neutral stance, free association, interpretation, and the attainment of insight. Experiential or behavioral change was implied, hoped for, rather than directly processed. Since then, a body of research has accumulated supporting the position that corrective emotional experience, that is, processing of painful experiences within a safe therapeutic relationship, is necessary to bring about real change. Concomitantly, much evidence has accumulated from brain research and evolutionary studies. Next slide, please. Showing that nervous system is primed from a very early stage to preserve memories of events that endanger our existence, as well as the avoidant defensive behaviors, fight, flight, freeze, developed in response to them. This ensures that throughout our lives, we do not ignore situations that could potentially risk our existence or well-being. Such behavior becomes locked in the emotional brain. So behavior learned early in life to protect against injury or abuse tends to become automatic, to generalize across social situations, and be very resistant to extinction. All this forms a negativity bias that is often activated in marital conflict. Next one, please. If we use neuropsychological terms, we can see that a spouse enters therapy carrying deeply held, repeatedly verified predictions. When he expresses anger or disappointment or an emotional need, what he expects as a response, rejection, indifference, or even punishment. When instead he receives attentive listening, empathetic validation, this constitutes a prediction error positive, which we now know triggers the release of dopamine and the activation of the dopaminergic reward system. Recent studies on animals and on humans show that the element of surprise, when a positive response is unexpected, it intensifies the release of dopamine and oxytocin, and the experience is encoded in the hippocampus as a new memory. This opens a window of lability. Not yet. This opens a window of lability. The new favorable experience can update the original prediction at its source, and with many repetitions, the negative prediction is gradually revised and the biochemical synaptic signature is rewritten. Now, going back to IRT, we will talk about red buttons. Next, please. When we are hurt by the person closest to us, the one supposed to be empathetic and warm, to be our safe harbor, it immediately triggers the existential defenses long practiced from the past. This is why a certain behavior that can seem trivial to an outside observer can provoke an intense and unforgiving response, such as defensive withdrawal, with silence lasting days and weeks. With the help of specific dialogues, the therapist helps train each spouse to identify their spouse's red buttons, those that link to traumatically sensitive areas, signaling danger, danger. Each spouse learns to avoid triggering these reactions and to adopt more understanding and empathic responses. Let's now move to eye contact. Next, please. In the third phase of IRT in a dialogue, the spouses are instructed to metaphorically cross the bridge toward the other person and actually attempt to imagine what feelings they might be experiencing about the subject under consideration. Keeping eye contact is encouraged, thereby activating mirror neurons. There is some overlap here between imago therapy and polyvagal theory. Our aim is to move from danger to safety. That is, the autonomic nervous system moves from a survival mode to a relaxed safety mode. Recent advances in neuroscience have revealed how observing emotional reactions in another person activates mirror neurons, which in turn stimulate the insula, a cortical region involved in interoception and emotional processing. And through the process of interoception, the observer begins to feel an emotion similar to that being witnessed. This resonance enables us to feel felt by the other, while the other also feels felt by us, while each partner retains a sense of differentiation. Next, please. A more intense experience used in IRT workshops, and one I often use in an advanced stage of therapy, is the cradling process. Here the couple are seated on the floor, supported by cushions, with one of them embracing the other, so that the cradle spouse's head rests close to the heart of the other person, hearing and sensing his heartbeat. This evokes a restoration of synchronization similar to mother-infant kangaroo skin-to-skin contact, a phenomenon extensively studied in kangaroo research by Ruth Feldman. The holding spouse encourages the cradled one to evoke early painful memories and related emotions while containing and supporting the spouse, even physically touching or helping him. Couples report this as a highly intense experience and the deepening of trust and safety in the relationship. Next one, I will now give a case presentation. The couple I have chosen to present here were seen online rather than in my usual clinic setting. Alon and Melissa started imago couple therapy while situated in 2 different countries. They are a couple in their 30s, married several years, who had been planning to undergo fertility treatments in Israel. However, Alon suddenly got cold feet and requested to hold the process. Melissa was deeply hurt and decided to leave the country and their relationship. Alon did not stop her. However, he started individual psychotherapy, and several months later, having gained some insight into his own motivations and defenses, he initiated couple therapy online, and Melissa agreed. Despite this unusual circumstance, a secure setting was gradually created for both spouses. They were asked to use time in the session to recover cherished memories from the beginning of their romantic relationship. Additionally, it was suggested that this crisis could serve as a welcome opportunity for positive change and growth. Thank you. In the dialogue, Melissa expressed her frustration about Alon's overdependence on his family of origin, by which she felt rejected. We are in the backseat of our marriage. We are not the driver. In subsequent dialogues, Alon worked on his growing desire to become more independent, to shed the role of being the youngest child, pampered but also managed and directed by his elders. 2 months into therapy, Alon decided to join Melissa in her own country. And since then, the sessions continued from their apartment, with both sharing the same screen. They usually sat close together on a sofa in their living room. And as is my practice with all couples, they were instructed to face one another and not the therapist on the screen, also looking into each other's eyes. As they were sitting at some distance from the camera, I could observe more of their body language and of their apartment background. On occasion, their cat joined our sessions, curling up close to Melissa. As they began establishing their new life together, you can change the screen. Alon started to voice his anxiety about impending IVF treatments. He had previously felt overwhelmed by the responsibilities ahead, particularly about providing emotional support to Melissa throughout the complex and unpredictable IVF process. Yet he had not been accustomed to sharing his feelings. Now Melissa's listening and validating him with true empathy encouraged him in his personal development. Alon said, "Even now there are fears, all these stressful procedures we have to undergo. Can I really become a father? But now I want to cope, not to avoid dealing with all these challenges." As the warmth between them deepened, Melissa began expressing the pain she had experienced over Alon's sudden change of heart. As Alon listened, reflected, and validated her feelings, with deepening empathy, she could open up more fully. We could relate her disappointment in the marriage and her dramatic act of leaving the country to early wounding in her relationship with her mother during childhood and adolescence. Her separation anxiety and her well-entrenched defensive strategy of avoiding close relations all were now re-experienced in vivo in the couple's relationship. These were topics which she had explored in individual therapy over the years. Yet, working together with Alon by means of IRT offered something new, a recurrent, lived, corrective emotional experience. To help transform their fears into positive expectations, the therapist employed the technique of providing sentence stems to Melissa to complete. The therapist says, "I can imagine myself holding my baby." Melissa repeats and continues, "He is warm, soft, smells good. I sense Alon sitting with me, holding us both. I feel happy, secure," and so on. Appropriate sentence stems were also offered to Alon to help him gradually visualize himself as a caring, responsible, and well-appreciated father. When they decided to take a break from therapy, Alon and Melissa were more grounded in their relationship, more secure in each other's love and support. They have started IVF procedures and have been able to accept help from their families while concomitantly making their own decisions and plans. Now to conclusion. The neuroscientific findings reviewed here, prediction error, dopamine release, memory reconsolidation, mirror neurons, and the polyvagal shift from threat to safety, offer a compelling explanatory framework for what happens in the room during imago couples therapy. They help us understand why the structured dialogue works. It is not only a communication tool, but a neurobiologically informed vehicle for corrective emotional experience, capable of gradually rewriting deep encoded relational predictions. My experience with Alon and Melissa and with other couples shows that this meaningful therapeutic work can indeed be conducted online. Although it lacks what Resnick and Resnick aptly term the animal presence inherent in sharing a physical space, online therapy carries some real advantages. One, it is possible when partners are geographically separated for any reason. Two, the safe empathic space cultivated in the therapist's office is transferred into the couple's home environment and can facilitate surprisingly deep explorations of intimacy and trust, and using the couples more easily in their own home. Still, I recommend that whenever possible, At least the first session and occasional subsequent sessions be conducted in person. This can balance the benefit of online therapy and the relational advantage of face-to-face interaction. Thank you for listening to me. And there is a list of references if anyone wishes to copy it. It will be available.
I thank you for letting me end with the scientific conference about trauma neuroscience. So our narrative was about how we could understand in the developmental stages. So this is like roughly the objective, and I will start also by mention some of the. So I mean I will start by mention some of the odd ratio. Can you go to the second slide, please? Yeah. So now before moving to mechanism, I want to look careful at what appear near to the top, which is emotional abuse and emotional neglect. And interestingly, the emotion itself, it often carries a hidden quality clinically. So we can identify physician injury. We can identify physical injury more easily, but emotional injury is harder to quantity, harder to observe, or even harder to patient to themselves to describe. So when we were previously talk about uh, how childhood maltreatment could be understood, it's become sometime neglect and sometimes become abuse. But in each side, you found the huge impact on borderline personality. Odd ratio was 38 in the abuse and 17 in the neglect. Yeah, so that means we should dig deep in understanding much how the earlier experience for child in general and predict who's the gonna be having some trait or disorder for BPD, borderline personality disorder. Um, so our research again, it was kind of reviewing or reframing the mechanism of the trauma or abuse or neglect. Can you go to the the third slide? Yeah. So again, we are already sure that there is huge evidence about the how much really connected early childhood trauma to the borderline personality disorder, but there's still many gaps that motivate our approach to the narrative study. One of them that theoretical gap, like we don't know exactly what is specific or what's the severity of the trauma that really have high risk to be lead to the child to be a borderline trait or disorder. Also from another gap, the huge terminological overlap between trauma, abuse, and adversity, and sometimes even childhood maltreatment. The third gap, it is the so we have four gaps. One of them is theoretical about understanding the exactly adversity. One sometime we use term of dose of adversity, and we're gonna talk about it. The other gap is about how much the overlap between terminological used for the early childhood abuse, and the other thing that pathway and mechanism, it's not fully understood. We know there is association, but mechanism is really vague. Can you go to the next one? Thank you. So I will appreciate also my team, Dr. Haya and Dr. Noop and Dr. Kadi and Dr. Awala, for their work to formalize was our framework, which is started from childhood maltreatment. Then we intentionally put action of aggression and action of repetition and action of withdrawal, just to make it uni and I mean highlighting each of them, because we know many of the clinician or consultant could also ask about the sexual, physical, verbal bullying, abuse, but maybe or most of them they could ignore or just forget to ask about those two things. For that, we are already just mentioned that all of them, they have huge actions. I mean perpetuation and withdrawal, and we will highlight more about those two things, and we'll keep at the end the aggression. In the middle of the slide here, we have mediator, which is also our work to try to doing like making mediator is a characteristic for both between trauma and symptom of borderline. So we're going to talk about the action and also about the type of trauma and also about the mediator and the end about the symptom of borderline. This triangle, it's almost similar to the previous one in the context, but in the way to look on it is better and more simple here, because we have again self-perpetuation, which is action perpetuation, and we have early relational deprivation, which is action of withdrawal, and we have also the third angle, emergent threat, which is really action of the aggression. So if we take it from another side, there is something well obvious, which is the aggression or threat, and there is something not usually seen on the opposite side, which is deprivation or withdrawal or neglect or action of omissions. And the third thing, which is just kind of perpetuation and continuation of the symptom. I mean, continuation of the trauma also. So yeah, we're gonna start now about perpetuation part, which is mainly the environment began to organize itself around the vulnerability, which is mean that once trauma and event started in the childhood life, the environment started also to figure the new developmental brain, and I mean the environment will push to the further adversity, and further adversity will push to further environmental change. At the end, you will find the trauma, it is kind of huge consequence between your cognitive, like the child in early stage, they will need some basic needs, they need emotion, but at the end, as the start school stage of their life, they will be stuck with many of the bullying and social tining. So I think the slide is next, doing the next, because I use it, save it in a different way. So I think it is, we cannot stop the next slide. But in general, this slide also the same for previous one, which is about the perpetuation. But there is three kind of perpetuation, which is regardless the how many trauma we have and how chronic the trauma and how much the continuation of the trauma. And if we do not understand how much the perpetuation and continuation of the trauma, we will not able to figure or detect the BPD borderline, because many of people, they will have small or little impacted trauma, but that trauma or stressors continuous for a whole of their life. At the end, they will develop borderline. So it's not necessarily to found like sexual abuse or physical trauma. It's not necessary to that level. Sometimes just perpetuation of small adversity could lead to borderline. Also here we have visible and invisible trauma, both of them with a different type. Like usually visible, as we know, there's fight flight response, fear learning, amygdala will be hijacked, but also deprivation, which is sometimes an opposite in origin, but it will be at the end intertwined with the same loop, which is developmental pathology or developmental pathway. So even if the child was just not learned how to deal with emotion, this will be really risk for BPD also. Or even if the child was just being in an absence environment without any invalidation or without any trust relationship, or even without uh, consistent caregiver, that will also lead to higher risk of the being borderline personality. So the better term to use deprivation and threat instead of use actually aggression and withdrawal, because dimensional model of adversity and psychopathology, it's become now more well known and worldwide how the psychiatric disorder could be categorized. And here, this is the third part of our talk, which is really type of deprivation. Like any person could say, how can I ask what the specific really questioning about deprivation? I mean, withdrawing need for children. So here is the example. One of them is what we call availability failure. Like there is no caregiver, or there is no one who is really give the child the role of figure or the father figure. Like, and the second thing which is really important about regulation, like when the child being more anxious or angry, they didn't learned how to deal with that emotion. The third thing, which is mentalization, absence of theory of mirroring theory, or mind, it's not well set about to name the emotion. And the third and the fourth thing, which is also we mentioned before, inconsistent caregiver, like fluctuating between giving care and abuse. It's also kind risk of being deprivation, or even being attend and taking care and then absence of taking care. It will also under trust failure, and this will affect the attachment security. So can we go to the next? So we finish perpetuation and we already finished the deprivation. These slide coming, three slide coming, it will be almost similar, but because we would like to do a slight connection between the brain network and outcome of the brain network. On the left side, we'll find the psychopathology, which is related to neurodevelopmental level. On the right side, you will find the early BBD outcome. So it's fair to say that there is no certainty about how much this neurodevelopmental will lead exactly to that symptom or not. But again, as we mentioned, we need to try understand the adversity in a different way, just to be able to much more understand what's really happened to the mind of borderline. It's a way to simplify the importance of that category, but it's not really evidence to understand brain network will lead to understand exactly how symptom emerge. So yeah, the next slide also the same thing, but we separate the deprivation from, like, we think that there is our brain network act different, or I mean react different during the deprivation state in comparison to threatening state. So that difference between threat and deprivation brain network state will lead to somehow or a little bit different in the symptom, but this is just theoretical suggestion, I mean. So can you go to the next also? Yeah, so here, the next one also. We did already that. Yeah, this is kind of summary for both of the previous two slides. So on the right and the left, it is the deprivation environment. Like ACC and SOLA, it will affect network, silence network. Through the deprivation, what will happen through the deprivation environment, and underconnected, while in a threat environment, the silence network will be connected. So that means both of them actually will lead to BPD, borderline personality, but maybe the path of each of them will be a little slightly different. So if we will not suspect that or expect that one of the form, that will lead much more to miss the case even at the later stage. Amygdala almost similar for both of them, but there is slight, because this is not threat tuned, but this threat tuned, but both of them hyperreactive. But stress regulation, which is related mainly to the stress hormone, yeah, we found a significant difference, because usually stress hormones become much more activated and threat environment, physical abuse, then that lead to down regulation and burnout. However, in silence moment and deprivation, maybe chronic slight activation without down regulation. The last thing, which is autonomic regulation, which is related to the heart, respiratory, GI, I mean the other part of the system, like vagal tone and fight, flight, freeze response. Actually, those two things, which is stress regulation system network and autonomic regulation network, 3 and 4, number 3 and number 4, there is no huge evidence about how much they are really direct or indirect affect the borderline symptom. But amygdala and silence network, there is actually evidence about how much brain is really affected by. But again, the pathway and the track, it's not clear for sure, not yet. Yeah, so this is almost similar, because we just want to say emotional dysregulation. It's really coming from emotional neglect and emotional abuse. I know this is, I found just one research from my narrative and literature review, who is really want to say emotional dysregulation. It should be emotional neglect and emotional abuse, but was really was evidence research. I think this is understand, it will help much better to trying to keep emotion dysregulation and a best mediating role between the adversity and the symptom. because we know affective instability and borderline personality having a huge impact in the symptom-wise. Without emotion dysregulation, you will not find any affective instability, or you didn't find any of the, many of the symptoms of borderline personality. Again, this is just kind of limitation what we face, like it is just narrative, no, not, it is the weakest evidence, as we know. There is a huge bias, but as a beginner in this trial and research, I think it will help many of the clinicians to figure out what really happened in the subconscious mind of borderline. That will help also sometimes to be more empathize with them. For sure, there is no causality. It's just about maybe some connection or framework or infographic framework. But there is evidence. I keep putting for each slide the reference for each slide. So if anyone want to check that, yeah. Can we do the next, please? I think we finished already. This is just kind of repeating what we already said, but yeah, I think mentalization lens, it's really missed. Many of my colleagues, like having 10-year experience in psychiatry, they have some of the courses or some of the books about attachment, how much that really affects borderline. But mentalization, it's really something in you. For that, I want like to highlight the mentalization lens more now. It's really also connected to the attachment, and even the trauma is really connected to the attachment, actually. So it's not separate, it's just kind of overlap between each of them. Mentalization, it was really old theory, but I'm not sure why there is no a clear study about how much that impact. The one of the best example for mentalization, which is EMBT. Can you go for the last slide, please? Yeah, EMBT, mentalization-based therapy, we know about it, but the evidence became recently much more better than before about how much just giving the child space to understand the learning how to deal or naming their emotion. Again, as we mentioned, attachment and mentalization could be in the same category. But yeah, really a relationship and issue, if not solved, the borderline personality will be always the risk to have a relapse, to have an episode, to have an resistance. So mentalization work mainly in relationship and ecology of the again reframing mentalization for the patient. And once we start that earlier, it will help much more if we start for reframing mentalization for someone who's adult, because the brain, once he is start to be habituated more, it's very difficult to stop that or even redirect. Yeah, thank you. This was just kind of way to understand the wide term, which is all we know, that PBD passing through early childhood trauma, but we didn't know how we categorize or understanding the overlap term between them, or understanding the pathway, or even know the role of brain networks. So this was my goal during doing that narrative review.
Good afternoon, everyone. My name is Marzena Gatafolus, and I work with children and adolescents after trauma, combining clinical praxis with research on post-traumatic growth. Today, I would like to share with you pilot data on Brainkinetik with Ukrainian adolescents refugees, focusing in particular on one clinic case. Today I would like to share with you pilot data on Brainkinetik with Ukrainian adolescents refugees, focusing in particular on one clinical case, a girl, Anna. The title of my presentation is Brainkinetik for Post-Traumatic Growth in Trauma-Exposed Adolescents, a neuroscience informed approach aimed at supporting mental health and resilience in adolescents after trauma. I bring together therapeutic work in Germany and doctoral research on post-traumatic growth in war-affected youth. This work is part of a 12-month longitudinal study with Ukrainian adolescents, refugees, including baseline 6-month and 12-month assessment. Data collection has been completed and mixed method analyses are ongoing. Today's findings are preliminary but already clinical very promising. Exposure to life-threatening evening turning adolescence is associated with a risk of PTSD with symptoms such as intrusive memories, avoidance, and hyperarousal. For refugee adolescents, 3 are additional cumulative stressors, forces displacement, family loss, or separation, disrupt schooling, which limits the effectiveness of traditional talk-based therapy and create a strong relation for body-mind intervention. Anna is a 13-year-old girl from Ukraine who fled based Mariupol after direct explosion for war-related violence, including the death of a soldiers who protect her. She also lives in a complex family system, parental divorce, material mental illness, limited contact with her father, and has gone toward migration, time in a refugee center, and eventually return to Ukraine with ongoing risk resilience factors. At the first session, Anna presents with profound emotional freezing. She sat almost motionless with silent tears and very little verbal attachment. On the PLC-5, she scored 54 points with a clinical threshold of 33, indicating severe PTSD, and at the same time, her PTGI score was 84 out of 105, reflecting high post-traumatic growth, clinical paradox where severe distress and growth process coexist. I understand post-traumatic growth as a positive psychological transformation after trauma, including greater application of life, new possibilities, deeper relationship, and a stronger sense of personal strength. Crucially, PTG does not mean the absence of suffering. It can coexist with PTSD. And your intervention aims to capture and consolidate this growth process. From a neurobiological perspective, PTG relies on neuroplasticity, the brain's capacity for adaptive reorganization after trauma. Key roles are played by the prefrontal cortex, emotional regulation and meaning making, the hippocampus, memory reconciliation, and the amygdala, fear responses, which raises the question whether motor cognitive intervention can effectively support these neuroplastic processes. Brainkinetik is a motor cognitive integration program designed to stimulate neuroplasticity and support post-trauma regulation. In practice, it uses cross-lateral movement, takes entering attention and working memory, and body awareness elements are in a non-verbal format that works particularly well with refugees, adolescents facing language barriers. And now I will show this video. In this short video, you will see simple brainkinetic exercise. Please pay attention to cross-lateral coordination, executive functions demands, and element of regulation toward movement. With Anna, this exercise were adaptive to her developmental level and trauma history. To stay within her windows of tolerance and strengthened her sense of agency. Anna's case became the starting points for a pilot study of Brainkinetik with 60 adolescents refugees aged 13 to 16 in two institutional settings, a refugee center in Germany and a boarding school in Poland. We use an exemplary pre-post design without a control group with 6 weekly brainkinetic sessions, 34 minutes each, developed in a group format. To access change, we use PTGI for post-traumatic growth, PCL5 for PTSD symptoms, and PCTPDQ1-LT to capture coping and defensive patterns. Assessments were conducted before the intervention after six weeks, and follow-ups at 6 and 12 months are planned to capture both immediate and long-term effects. Across the first 2 sessions, Anna showed coordination difficulties and frustration, but gradually starts to engage with the exercise. Over the following weeks, we observe smoother motor performance, better response to verbal instruction, and first moments of positive affect. And by the end of the cycle, she was performing complex movement sequences and spontaneously interacting with peers. In the far simple of N60, we show our recruiting patterns in initial method difficulties and tension, followed by emotional tolling, increases body awareness, and greater social engagement. At the speed and depth of change were adolescents with higher baseline PTG and more stable family support tended to show faster and more pronounced improvements. Preliminary quantitative results showed that most participants experiences reductions in PTSD symptoms on the PLC-5 and increases in PTG on the PTGI after 6 weeks of Brainkinetik. On the PSTPDQ, we see a trend toward more constructive coping strategies and more adaptive defensive mechanisms, although with considerable individual variability. These findings suggest that Brainkinetik may serve accessible trauma-informed intervention for war-affected adolescents. The proposed mechanism involves integrating movement and cognition, stimulating neuroplasticity in prefrontal and interhemispheric networks, with bypassing language and cultural barriers. Hypothetically, cross-lateral exercise enhances interhemispheric integration, motor challenge engage the prefrontal cortex, and rhythm and body awareness modulate to HPA axis and automatic regulation. Clinically, Brainkinetik appears to be developmentally appropriate, culturally flexible, and useful as an adjunct to talk therapy or as an early stabilization intervention. The group format allows implementation in schools, community center, and refugee shelters, making it a potentially scalable public health tool for war-affected youth. This pilot has the usually limitation, no randomization or control group. A sample of N60 relies on self-report measures and limited setting diversity. Even though it demonstrates feasibility, acceptability, and promising trends, providing a solid basis for moving to phase 2, a randomized control trial. Next step include RSTs with an active control group, neuroimaging studies such as fMRI and EEG, and biomarker analysis, for example, cortisol and BDNF, alongside cross-culturally replication in different trauma contexts. The aim is to build a robust evidence base with maintaining the practical accessibility of Brainkinetik as an intervention. In summary, Brainkinetik emerges as a promising, accessible trauma-informed intervention for war accept adolescents, we see a dual effect. Reconduction of PTSD symptoms and facilitation of post-traumatic growth with good acceptability across settings. These findings justify moving toward more rigorous studies while already pointing to practical public health application. Thank you very much for your attention. I will be grateful for your questions, comments, and methodological feedback. And I am open to research collaboration, particularly around phase 2 RSTs and neurobiological projects. Please feel free to contact me by email. I'm happy to share more detailed data and exercise from working with war-affected youths. Thank you very much.